Next candidate.
Assalamu alaikum, sir.
Salam. Could you request control?
Yes, sir, I have requested.
Candidate 6, by the way, you answer the last question I saw, but you answer after, not the first one to answer. Renal artery
It's okay,
stenosis.
sir.
Okay, excellent. Doctor, this is, 1 second. No problem. Let's see this case. Doctor, this 55-year-old female patient presented with abdominal pain and vomiting. I will bring from the beginning. This is the most superior slice. You can scroll?
Okay. Sir, I will try to scroll.
You can. Yeah, scroll. Oh, 1 second.
Oh, sorry.
Another case. I guess you should answer. Us. The case is biased. It happened. Okay. Did you see? Use our case. Another case
Yes,
because
sir.
you see the answer of last case. This is 85-year-old male patient presented with severe headache. Use the arrow, please, if you can.
Okay, sir.
Mm.
Um,
Okay,
okay.
go
I
on.
think now it is scrolling. Okay. So
Yes,
this
go on.
this is CT brain of an
Yes.
85 years old man who presented with severe headache, and these are plain images. And I will go through the images. I can see a hyperdense focus in the right parietal region with marked surrounding edema. However, I cannot see any significant mass effect or midline shift in this case. I will further scroll. I can see another focus, similar looking focus, and I can also see there is some hemorrhage in the subarachnoid spaces as well.
Okay.
Okay, I'm going down. Again, I can see there is hemorrhage in the subarachnoid space. However, I cannot see any other similar focus or any other hemorrhage. Their ventricles are slightly dilated, likely related to the age of the patient. Yes, there is a age-related brain atrophy in this patient. I am going down and I'm having a look at the parenchyma. I cannot appreciate any other abnormality in these lesions. I will
Yes.
scroll through to the last image to see if there is any other abnormality. I cannot appreciate any other abnormality in this. So, so these are hyperdense lesions in the right parietal lobe of a 85-year-old man. Considering the age of this patient, my first differential would be hemorrhagic metastasis. In this case, other differentials could be vascular malformations. Um, there could be amyloidosis in this patient, but my first differential would be hemorrhagic metastasis, and I would like to review further. I will, if any prior imaging is available, I would compare it with this, and I would also like to review other investigation
Could you
if
have
there
a look?
are any.
Could you have a look in the most superior slice, please?
Okay, sir.
What do you think?
So, sir, I think this is a hyperdense sigmoid sinus, and this could be a case of dural venous sinus
Which
thrombosis.
sinus? Which sinus? Again,
Superior
what is it?
sagittal sinus appears thrombosed, and this
O-
cortical vein is also thrombosed, the superior cortical
Okay,
vein.
okay. So,
So these could be thrombosed veins with dural venous with intraparenchymal venous hemorrhagic infarction.
okay. What's your next step?
So next, I would like to do MRI or post-contrast CT to CT venogram to confirm the diagnosis of superior sagittal sinus thrombosis.
What history do you want to ask a patient about?
I would like to take the history of any dehydration as he is 85-year-old male. So I would like to take history of any dehydration. I would also like to take history of uh, any bleeding disorder in the patient, protein C or S deficiency. I can, um,
But take
if
care,
she
this
was,
is
if it was,
80, 85-year-old. 85.
so some malignancy, he could be taking some medicines which could lead to sinus thrombosis or some
Why is
diarrhea, a
this?
history of diarrhea,
Why is this not an arterial infarction? Why?
because it is not following any particular territory, and
And what else? But really, it looks like wedge shape.
and
Frank, frankly, it looks like. What else?
yeah, venous infarcts are mostly hemorrhagic. Arterial infarcts are not mostly hemorrhagic, and they follow arterial infarcts. They follow a specific territory. This also,
Mm-hmm.
I can appreciate thrombosed vessels, which are likely thrombosed veins,
Okay,
which have
understand?
led to this.
Okay, and look here. Some of the cortex are intact. Look, look. Some of the cortex
Yeah.
here even. When the arterial infarction become hemorrhagic, when?
Yeah, it can become, it can have hemorrhagic transformation. If it is a large infarct, it can have hemorrhagic transformation, especially when the patients are given anticoagulants. It can lead to hemorrhagic transformation of the arterial infarcts.
Okay, what else? In other,
Uh,
what other situation arterial cerebral infarction become hemorrhagic or show some hemorrhage?
uh,
Mm-hmm.
Arterial infarct, they can show hemorrhage, they can show luxury reperfusion um, after,
Hemorrhage, not hemorrhage, not luxury perfusion. After perfusion, after
yeah, after,
thrombectomy, after the IR
yeah,
team
yeah, after, yeah,
remove the impulse, it will the rapid or the sudden perfusion, okay, will cause some hemorrhage, okay,
yes,
and embolic arterial infarction is common to be hemorrhagic. Thank you, doctor, so much.
okay.
My advice, take a home advice, home message. When you are examining any examination, especially in Viva, at least one case, you must present it with it, and the answer in the last slice here. Okay, like the case before, the case just before you. The answer the problem was jejunal perforation, but really the key was in very, very superior slice. The most superior slice, just very small foci of pneumoperitoneum under the diaphragm. Here also, by the way, you give a good differential diagnosis. It may be hemorrhagic meds like this. Okay, but in this case, the answer is a different scenario, completely different scenario. If we look carefully from the slice number one to the last slice, we will run through the proper pathway. Here, see hyperdensity in the cortical veins in the SSS. Down, down there are edema surrounding hyperdensity. So this is definitely a hemorrhagic infarction. And we will talk about hemorrhagic myths as just a differential. And we should mention very less likely. Very less like why? Because myths almost multiple, okay, multiple variable in size, may involve the cerebellum, and in this case, not a typical scenario. The myth is not the logic scenario. Okay, you did very well when you told me in non-malignancy patient due to the hypercoagulability state, uh, venous brain thrombus, superior sagittal or dural sinus thrombosis is very common due to hypercoagulability state. Thank you, doctor, so much. Next candidate.
Thank you, sir.
Welcome. Next candidate, are you ready? Hello?
Dr. Honia,
Dr.
please proceed.
Hello, Assalamu alaikum.
Yes. Yes.
Salam. Doctor, this is
Okay.
70-year-old male patient. Okay.
Okay.
70-year-old male
Uh,
patient underwent this nuclear study.
okay. So I'm presented with MDP bone scan image, static image from MDP bone scan of a 70-year-old male patient. I can see that there are multiple areas of radio tracer uptake seen in the bilateral rib cage and also in the vertebral column. An area of radiotracer uptake is also seen in the region of the right scapula and along the left skull vault. There is an area of intense uptake noted in the left hip bone in the region of pubis and ischium. However, I cannot see the bilateral kidney, so it is likely a super scan with more uptake in the axial skeleton as compared to the appendicular skeleton. In a 70-year-old male
Excellent.
patient with super scan, sorry,
Excellent.
okay.
Go on.
In a 70-year-old male patient with a super scan and focal areas of increased uptake in the axial skeleton, my top differential would be a metastatic disease, likely from a prostatic cancer. I would like to correlate with the history of the patient, any clinical notes. If it's the first presentation, then I will uh, I will discuss the findings with different clinician, will advise PSA levels, ultrasound, and MRI of the prostate, and staging CT scan of the chest, abdomen, and pelvis with a referral to the urological MDT for further management.
The clinician is has a conflict with you, and after you telling him your differential, and
Okay.
he saying that there are other causes, other primary than prostate. What will you do?
There are other primaries other than prostate. Then other differentials could be of osteoblastic metastasis from urothelial carcinoma, transitional cell carcinoma. It can
How
be
could you prove?
from
How could you prove to him this is a uh, prostatic metastasis?
I would like to
Radiological.
proceed with the PET CT with PMSA specific
Excellent. What is the
PMSA. Yeah.
BSMA? What
It's
is the
prostate specific
BSMA?
membranous antigen.
Brilliant. Sometimes they call them in Egypt, especially gallium plasma,
Yes.
BSMA, prostatic specific membrane
BSMA.
antigen. Brilliant. Doctor, your colleague, the urology clinician, agree with you and to do an MRI prostate. Okay. Could you describe for us your expectation,
Yes.
your finding for a prostatic cancer in MRI prostate?
Yes, in MRI prostate, the prostatic cancer appears hypointense on T2 weighted images and shows diffusion restriction on DWI and ATC.
Which zone?
And sorry,
Which zone in the prostate? Peripheral
which
zone or central zone
peripheral
or
zone?
transitional zone?
Yes, peripheral
Right.
zone is more involved in the region of the for carcinoma, and central zone for the benign prostatic hypertrophy.
Okay, if you do an X-ray, which type of metastasis you will see? Skeletal survey.
Sclerotic type.
Why
Sclerotic
prostate?
type.
Excellent. Why prostatic cancer is sclerotic?
Because of the deposits, cancerous deposits in the region of the bones, intramedullary.
Many cancer deposit within the medulla, likely
Yeah.
multiple myeloma, and the multiple myeloma is lytic. Why specifically? Why specifically prostatic cancer? Prostate is sclerotic.
These are the sclerotic osteoblastic mets, which increase the osteoblastic activity of the marrow cells rather than osteoclastic activity.
This is a political democratic escaping.
Sorry, I didn't know the
A
exact
political
answer.
answer. No. Sure, the tumor secretes something, some substance that activates the osteoblastic activity. This is a half answer,
Yes.
but I'm asking specifically about this substance.
Hmm. I didn't
Uh,
know about that.
I think some alkaline phosphatase, something like this. But see, my colleagues, thank you very much, doctor. Your answer is very, very good. But generally, any osteoblastic metastasis activates the osteoblast. Okay. Why? Due to some secretions. I think in prostate, it is related to alkaline phosphatase, something like this. I want to ask you, why multiple myeloma
Yes.
is a lytic lesion? If you don't know, I will answer. You know or not?
Multiple myeloma are cooled on the bone scans and they are uh, lytic lesions on the
Inactive.
X-ray
Yes.
and they have osteopenia.
Yes. Multiple myeloma, thank you, Dr. Honia. Multiple myeloma is originally a plasma cell, abnormal plasma cell within the bone marrow itself. So, it is not activate at all the osteoblastic power of the bone. It not initiate or stimulate the osteoblastic activity of the bone marrow. Okay, this is a cause of explanation related to me. It is a member of the bone marrow that abnormally enlarged, abnormally become increased in size, and finally, this plasma cell didn't cause or secrete something to activate the osteoblastic activity. Okay, thank you so much. Take care, my colleague. The specific tracer related to prostate cancer called BSMA or BASMA. Okay, it is used specifically, um, number one, to make sure يعني to make sure this is related to prostate. Number two, even to describe or discover the cancer prostate itself, because it will bind to attach to cancer prostate. Why? Because it is very specific. This is SPECT, by the way. This is SPECT, and all of us know SPECT is a fusion between the nuclear and the CT. This is know us or give us some information about the anatomical details of the patient. Thank you so much. Do we have another candidate? We can take another one.
Assalamu alaikum, sir.
Assalam. I don't know if we take this one before or not. What is? Okay.
Okay, sir. Chest pain.
Go on.
Okay, this is X-ray chest of a skeletally mature patient. The patient is in ICU setting, as I can see that the multiple chest leads are seen in situ, and there is also a tunneled catheter noted in the right atriocaval junction in satisfactory position. However, coming up to the cardiac size, it appears to be enlarged. There is also evidence of horizontal lines noted in the periphery of the right lower lobe that may represent evidence of pulmonary edema. I can also see that there is a bulkiness of the right bilateral hyla are bulky. Predominantly, the right one is more bulky. There is also mild upper lobe diversion seen, so it is most likely representing a patient with the congestive cardiac failure with developing pulmonary edema and pulmonary hypertension. Further, I would like to know the previous record of the patient if available and previous X-ray for comparison. And I will tell the findings to the referring physician. And if the patient is in the department, I will do CT chest for further evaluation. So can I ask for control?
Okay.
Or sir, if you are doing, I will see it.
Okay.
Okay, this is plain CT, in which I can see that there is some thickening of the mediastinum. Heart shadow is enlarged. There is mild ascites noted. Central catheters are seen in SVC with the appropriate position. There is also a calcific focus noted in okay, the aorta is showing peripheral calcification, which is medially displaced at the level of the descending thoracic aorta, which may indicate that there is mural thrombus, which is causing some displacement of the calcific intima. However, I will see post-contrast images to see any perforation or any ulcerated plaque for further evaluation, because it is likely representing acute or it may represent acute aortic syndrome, Stanford type D. But I would like to see the whole post-contrast study for it. Okay, these are the post-contrast images of the patient. Okay, there is a significant thickening noted around the ascending aorta, arch of aorta and descending thoracic aorta with plaque. Yes, there is a small aneurysm noted in the descending aorta also. So it is most likely representing, and now I will see the continuity. There is mild hypoperfusion. No, there is no intimal plaque noted. There is no dissecting plaque noted, so it is acute aortic syndrome, Stanford type B. I will manage the patient. I will tell the findings to the referring physician, and I will refer the patient to cardiology department for the control of hypertension and symptomatic treatment if needed. I will see, sir, I want to see the extent of this. It is seen at the ascending aorta also. The
Are you
mediastinal.
sure? Are
Yes,
you
sir,
sure?
it is.
Look.
Sir,
No.
okay, sir.
Look. I'm kind examiner. No. See,
Mm-hmm.
this is the ascending. See?
Yes, sir.
Right.
Yes, sir, it is somewhat at.
So what's
Yes,
your
sir,
final
it is.
diagnosis?
Now, sir, it is acute aortic syndrome or intramural hematoma type A, Stanford type A. I will refer the patient to cardiothoracic surgery for further evaluation, and I think there is a streak of pericardial effusion as well.
Okay. What is your next step?
Sir, as it is type A, Stanford type A, I will send the patient to cardiothoracic surgery for further evaluation, and I will also request for comparison with the previous reports if available, and I will also refer the patient for evaluation, and I will also see the end organ ischemia, but I cannot see any ischemia in the provided images.
What is the difference between, why is this not a dissection?
Sir, what, sir?
Why is this not a dissection?
Why is it not dissection? Sir, I cannot see any in the flap, dissecting flap is not seen, but the ulcer was seen at the descending thoracic aorta. That was a penetrating ulcer.
Okay, what is the
There is no
difference
flap.
between dissection and deep penetrating ulcer and intramural hematoma?
Okay, sir. Sir, the flap, the dissection is in which we can see a flap, which is dissecting the aorta between two parts. One is the false tract, and one is the true lumen, basically. And in the intramural hematoma, there is blood between the intima media and intima so the internal and middle part of the aorta, in which the blood is accumulating and it displaces the calcification of the intima medially. And in penetrating ulcer, there's an outpouching from the intima, which is continuous with the lumen, and it may dissect into the thoracic cavity, and further it can cause mediastinal hematoma also.
Okay, first, thank you to pick up this in the non-contrast. Very great pickup. See, my colleagues, see, the patient is 50, and this is very important to look at calcification. Calcification is eccentrically displaced, and the patient has chest pain. Okay, and if you look here, you will find some subtle hyperdensity mural. So our colleague asked for post contrast, which is very clear. There are something abnormal, at least in the wall. Doctor, why is this not atherosclerosis? Why? Why? Don't
Sir,
don't give me a clinical cause. Radiologically, why? Why is this
sir,
not? Somebody will tell me, doctor, this is atherosclerosis. Why?
no, sir, because in atherosclerosis, there should be first the age, then there would be age of the patient would be more than this, and there would be more calcifications. And I cannot see any significant calcification, but there are some ulcerations noted.
Okay, but there are many tips here. See, here, the sickening start almost posteriorly. Okay, Hello?
Sir,
Hello?
hello. Yes, sir. Yes, sir. Now I can hear you.
Sorry for some internet problem.
No, sir. It's okay.
I will give you one very important tip here.
Yes, sir.
1 second. Here, the sickening starts posteriorly, okay? And then go down, 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 down. It is started to be left lateral and anteriorly and more anteriorly. See, completely
Yes.
anterior,
Yes, sir.
okay? This
Yes,
is
sir.
not logic with atherosclerosis, especially
Hmm.
and the inner border is very smooth in
Yes,
the
sir.
whole length. See, complete anterior thickening. This is, remember us really with the changing position of the dissection, but we can't find any contrast here. And the patient has acute chest pain, okay?
Yes, sir.
So have another look. Another look. Oh, doctor, we find some contrast here. What is this? This is some contrast. Oh,
Hmm.
connect both findings with each other. Patient has acute, very severe chest pain. Okay, acute aorta syndrome, and we find some in the pre-contrast, some little bit hyperdensity here, and this suspected either a hematoma or atherosclerosis. Changing position looks like dissection, so it is an intramural hematoma. Okay,
Yes, sir. Yes,
intramural
sir.
hematoma. Especially try to pick up any extension in other arteries, in the mesenteric vessels, in the major vessels superiorly. Unfortunately, you will not find. Okay.
Hmm.
Second point, what is the difference? This is not type A, my doctor. Why? Look here, very normal ascending,
Okay.
very
Okay, sir.
normal diameter. Compare here the diameters. At least if you are confused, compare. Look,
Hmm.
completely normal. Okay?
Okay, sir.
May take some part of the arch. Okay, I may agree with you, but this is not Stanford A at all. It
Okay,
not
sir.
involved at all the ascending. It involves the descending till the superior mesenteric and maybe part even the arch. It is just started after the left subclavian, so it is
Okay, sir.
affecting the descending. Number three, I ask you one question. What is the difference between dissection? Could you look this? Could you see this new screen?
Yes, sir.
Dissection, intramural hematoma, and deep penetrating ulcer. See my colleague. Deep penetrating ulcer will be like this. Pouch ulcer. This is very easy. Just pouching of the contrast here, like here, like this one. Look here. This is very important, by the way. This question is very important. Look here. Some localized contrast extravasation. Some
Yes.
localized. No
Yes,
any
sir.
extension. It looks like the duodenal ulcer, regular ulcer. No any extension up or down. If you look here, look here, just very small collection of contrast. Okay, my colleague?
Okay, sir.
And from the penetrating ulcer, the blood go inside the intima media
Yes, sir.
of the aorta, only one entry. So go without exit. Why this not considered as this case considered as dissection? Because you only see the entry of blood, which is the deep penetrating ulcer, this one. and you can't, this one, like this, you can't see the exit. So the difference between the penetrating, the intramural hematoma and the dissection is intramural hematoma has only exit of blood without, entry of blood without exit. Okay, my colleague?
Yes.
So the blood clotted inside the lumen. Let's see the diagram, please. In the ulcer, in the hematoma, intramural hematoma, this is the entry. The blood go inside the media and clotted inside the media without an exit. In
Okay.
dissection, there are entry and exit. So in the dissection, this is flowing blood, not clotted blood. So when you give contrast, in dissection, I will give you one case. You must see contrast. You must see false and true lumen. Why? Because you have entry and
Entry and
exit. Whatever the entry, where is the entry, where is the exit? Suppose this is the exit. So in summary, the difference, number one, the answer is just outpatient. This is very easy. The intramural hematoma is an entry of blood without exit. The dissection must have entry and exit of blood to be a patent lumen that can allow with a contrast flow. Is it clear for all of you, my colleagues? This is
Yes,
very
sir.
important. Okay.
Sir, can I ask a question? So, sir, it's just important to see where the plaque or ulcerating plaque is. The hematoma can extend up till the ascending or arch vessels also.
Again, please, I didn't get your question. Again. Hello?
Yes, sir. I have asked that if we categorize dissections in Stanford A and Stanford B, we will categorize it on the basis of the ulcerated plaque, not on the basis of the hematoma. It can extend up to the arch vessels also. Is it true? Is it like this?
See, as I know, Stanford classification has been done originally for the dissection. This is the main
Yes, sir.
purpose. Okay.
Yes, sir.
But I will tell you something. There are no big difference between dissection and intramural hematoma. Why? Because sooner or later, this intramural hematoma will rupture.
Will become dissection. Yes, sir.
Know the steps of pathology of this
Mhm.
dissection. See, this is a system. By the way, it's very, very brilliant. Very brilliant. What happened? The pathology should start with ulcer. Okay, and suppose in day 1, 2, 3. Okay, and if this ulcer isn't treated, it will extend and develop into, it will enlarge it. Okay, to be a hematoma. Are you
Yes,
agree
sir.
with me?
Yes, sir. Yes, sir.
This patient is old age, atherosclerotic, and almost have hypertension. So the blood go inside. Intraluminal pressure are increasing. So later on, it will cause an exit. So
Okay.
fight will cause exit. Correct? Are you agree with me?
Yes. Yes, sir.
So the dissection not start all of sudden dissection. It may be deep penetrating ulcer. It may be hematoma, and after that, the lumen due to hypertension. The hypertension, a new exit has been created. Somebody will ask me, Doctor, intramural hematoma, the blood already clotted. Okay, but in hypertension, the blood flow, the blood pressure is more stronger than the hematoma. The blood pressure itself cut the very, very, very strong tunica media. Do you think do you think it can't dissect the hematoma? It is very possible.
It can. Yes.
Did, do you get it?
Yes, sir. Sir, but the
So
voice is
my,
interrupted. But I
yes,
have
again and
understood the concept. Thank you, sir. Thank you so
yeah,
much.
again and again, my colleague, the dissection start as ulcer, which developed into hematoma, and later on may develop into hematoma and then developed into dissection. Or this ulcer, this ulcer may directly go to be a
Dissection.
dissection.
Yes, sir.
Okay.
Thank you, sir.
Sure, dissection may come all of a sudden, maybe. Okay. Let's revise our case. This is a large descending aorta hematoma. It is treated as a dissection. Why? Because the aorta here is about to rupture. This is a very, very weak now and the pathological wall. What is the means of treatment here? EVAR, endovascular stent, endovascular aortic repair, not surgical. Why? Because this patient is stable. I wanted to tell something here in the X-ray. You forget to talk about this widened aorta. This is
Unfolding of
very
aorta
important.
and it's widened.
Not
Yes.
no, not folding, not unfolded
Widened.
aorta. See the aorta.
Yes.
This is the contour. Suddenly came here convex
Hmm.
border.
Dilated.
Okay, and the patient has a chest pain, and this is not a young patient. Okay, 50 is not a young. Okay, my colleague. Thank you so much.
Okay.
Thank you, Dr.
Thank you, sir.
Randam. Thank you. Goodbye.